I tell people, it's hard to predict exactly the benefit that you will get from RNS, but in every case, we learn about your epilepsy by virtue of the data. That is true in every person I've ever taken care of with RNS. But it's also true that we are learning about epilepsy as a whole in a way that is revealing some of the fundamental underpinnings, some of the mechanisms, some of the temporal patterns, how the brain works, why seizures are generated, what makes seizures get better over time. These are things that having long-term EEG data can be very, very revealing about.
There's an epilepsy treatment called RNS, or responsive neurostimulation. It's basically a flash medtech device that detects potential seizures and it zaps them before they can spread. But it might be doing other really cool things as well. As our guest, Dr. Vikram Rao, tells us, researchers increasingly do think that it might be changing brain networks over time in a positive way. And in the future, similar technology might even be able to help us with conditions like depression and OCD. So, Vikram, thank you for joining us today. Could you tell us just a little bit about yourself and what you do, please?
Yeah, sure. So I'm an epileptologist and a professor of neurology at the University of California, San Francisco. And we are a level 4 epilepsy center. So we really offer all the treatments that are possible for people who live with epilepsy. And I've been doing this for about 14 years now.
Fantastic. And why specialize in the epilepsies?
Well, I just think that I always found seizures to be really fascinating because they're so diverse in the way that they present, and because there are so many treatments that are available for people who experience seizures. Really, I would argue maybe more treatments than most other areas of neurology. And so it's very exciting for me to try and tailor a treatment plan with all of these tools for a given person.
How things have changed over the past 20 years, eh?
Very much so. A sea change in so many ways in our field. That makes it very exciting and most importantly, good for the patients themselves.
So tell us about RNS, or responsive neurostimulation, because you are a bit of an RNS king, aren't you? Expert. So give us a bit of an overview. What is it?
I forgot my crown, I suppose you could say. Well, this is a really remarkable transformative technology. It was approved by FDA in 2013. So it's been available in the US anyways for just about 13 years. Still not approved elsewhere, but hopefully soon. This is an implantable device that works by delivering direct brain stimulation, electrical stimulation to the brain to reduce seizures over time. And colloquially, this is called a pacemaker for the brain, which I think is actually a pretty apt description. It's a device that's constantly listening to brain activity. And if the brain waves are normal, it doesn't do anything. But when the brain waves become abnormal, such as at the start of a seizure, it responds by delivering some electrical stimulation to the epicenter of the seizure to try and essentially snuff the seizure out before it takes hold.
I like that, snuff the seizure out. I haven't heard that one before. And is this an intracranial implant? I mean, how would you compare it to VNS, for instance, which, is sort of shoulder to skull, that type of thing?
Quite different, actually. So VNS is totally extracranial. So the pulse generators in the chest and the lead wires in the neck on the vagus nerve. The RNS device is a cranial implant. So the device itself sits in a full thickness craniectomy, and it has 2 lead wires that have 4 electrode contacts each, and those are placed inside the brain at the site or sites where seizures come from.
And how long is the surgery for this? And how often do you need to have things replaced?
Yeah, the surgery takes probably around 3 hours for a typical implant, and patients typically spend 1 night in the hospital, as they would after, most brain surgeries. Most people are recovered very well the day after, or maybe after 2 nights, and they go home. And then we see them back a couple of weeks after surgery to check on the scalp incision and to make sure everything's looking okay. In terms of the replacements, luckily, this battery that we have on the device now lasts for about almost 11 years with average use.
Wow.
So it is not a rechargeable battery, but luckily people don't have to have it replaced too often since the battery life is quite long.
Gosh. And so give us some numbers when it comes to RNS then, like what percentage of people with refractory epilepsy might benefit from it?
Yeah, great questions. So RNS is best suited for people where we know where the seizures arise from, meaning which brain regions generate the seizure activity. But when those 1 or 2 foci are not amenable to surgical therapy, We like to do epilepsy surgery to remove brain tissue when we can, because that can be potentially curative for many people. But oftentimes that's not feasible because the seizure focus overlaps with a critical brain region, such as one that mediates language or movement or vision. And in those cases, or cases where seizures come from more than one spot, for example, from each temporal lobe, those are cases where it's not really feasible or safe to do surgery. And those are the cases where RNS is particularly helpful, because once we've pinpointed the seizures, we can place wires at those locations that start to treat the seizure foci.
So you can basically zap more than one area at one time.
You can. The device has 2 lead wires. And so if there's a single focus, we can place both lead wires in the same spot and kind of double down in that area. But if seizures arise, for example, from each hemisphere independently, one wire can go on each side. So it does give you more flexibility in treating people with multiple seizure foci.
Maybe this is a silly question, so please forgive my ignorance. But when you place it, when you do the surgery, is it usually just in one specific place, or does it depend upon which part of the brain that you are trying to help the person with?
It's a wonderful question, actually, because the answer is it depends. Classically, I would say the wires can be placed in many, many different brain regions, and the location depends entirely on where the seizures were found to come from. So if somebody's seizures came from their hippocampus, we would put an electrode in the hippocampus. If the seizures came from their motor cortex, we would put a lead in the motor cortex. However, one treatment approach that's sort of come into vogue recently is something called thalamic RNS. The thalamus, as you know, is a structure that's sort of deep in the brain. It sits atop the brainstem, and we think of it as a hub. And that hub has spokes or connections to very diverse parts of the cortex, of the overlying cortex. And so an emerging paradigm is to place an electrode in the thalamus and to stimulate the hub and take advantage of those spokes to treat the wheel, meaning the rest of the brain, as it were. And so in that sense, we're not putting the electrodes where the seizures come from. We're putting them at a place that talks to all the places where the seizures come from.
That sounds borderline more preventative rather than treating.
It's a really interesting thought. And in fact, RNS was conceived as almost like a defibrillator, if you wish, something that would detect a seizure as soon as it started and then nip it in the bud, maybe you could say, like a cardiac device might. But if you really think about it, maybe what you actually want is for the seizure to not begin in the first place and to have a more, as you say, preventative approach. I actually think that is not how this was conceptualized, but it may in fact be how it actually works. We're learning that although RNS probably can terminate seizures in some cases, most of the RNS stimulation that's being applied is actually outside of seizures. And so people are now thinking that what is actually happening is the therapy over time is sort of rewiring brain circuits and engaging endogenous plasticity mechanisms to make the brain less likely to generate seizures in the first place. So to your point, more of a preventative approach.
How does it do that? Are we looking at interictal activity and like what the things that nobody else sort of tends to see in between seizures and then faff about with that to mold the new network?
Yeah, that's right. We configure the RNS device to detect abnormal activity, meaning, epileptiform discharges. And of course, we're thinking about the discharges that are present at the start of a seizure, but people have sparks in between fires. And the device also makes detections interictally between seizures and delivers stimulation in response to those detections, because for all the device knows, every one of those sparks could turn into a seizure. So it's trying to treat all of them. And that's why the vast majority of stimulation typically is delivered in the interictal period, which is exactly the opposite of what you would think if this was a seizure aborting device. So not that doesn't happen, but many of us are thinking now that actually the real action is in the interictal period, and all of that chronic ongoing brain stimulation is having a therapeutic effect, which, truth be told, we don't understand fully at a mechanistic level, but we're learning.
Very exciting. What percentage of people do have a degree of seizure control?
Yeah, let's talk about efficacy first. So we have, fortunately, really high quality long-term clinical trial data to teach us how well this works on average. So the RNS long-term treatment trial was published in 2020 by Dr. Nair and colleagues. And that showed that over the course of 9 years, the median reduction in seizure frequency was around 75%. More recently, just this year, actually, in the Neurology Green Journal, Dr. Eliashev and colleagues published the results of the 3-year post-approval study, which showed that in the real world contemporary practice, people are doing even a little bit better with a median reduction in seizure frequency of 82%. It's worth noting that a minority of people treated with RNS become truly seizure-free for the long haul. So we do think of this still as a palliative therapy and not something that is likely to be curative for most people. But that said, this can still be transformational in terms of improving seizure control over time.
And what are other potential impacts of the device?
Yeah. I would say the principal thing, maybe the most eye-opening thing for me that I didn't anticipate when we started using this, is the power of the data that is stored by the device. So even as the device is making detections of abnormal activity and stimulating in response to that, it is also storing recordings of brain activity, storing the counts of the detections of interictal discharges, for example. And patients are able to download data off the device and transmit it to an online data bank that clinicians can review. And it turns out that data is a treasure trove of information, because this is the only way that I know of in neurology to record intracranial EEG data over years from patients who are living their lives in a natural environment, on medicine, doing all their normal activities. And it's incredibly informative what you can learn when you look at brain activity over such a long temporal scale. For example, cyclical patterns of activity in the brain, response to medicines and other therapies that we offer to patients. We can sort of quantitatively gauge those outcomes. We can, if people have 2 seizure foci, we can determine over long periods of time what the ratio of seizures coming from those 2 locations are, and that can inform future therapies. And, many more things. One of my research interests is in seizure forecasting, which is the notion, like weather forecasting, of trying to give people a likelihood estimate of the chance of a seizure over some given horizon. Just like you would say there's an 80% chance of rain tomorrow. And it turns out that data from RNS can be very valuable for that as well.
So, and that could benefit the individual, as well as, assuming one is okay to share one's data, actually other people around and people of the future in understanding the epilepsies better.
That's right. Yes. It's really both. I tell people, it's hard to predict exactly the benefit that you will get from RNS, but in every case, we learn about your epilepsy by virtue of the data. That is true in every person I've ever taken care of with RNS. But it's also true that we are learning about epilepsy as a whole in a way that is revealing some of the fundamental underpinnings, some of the mechanisms, some of the temporal patterns, how the brain works, why seizures are generated, what makes seizures get better over time. These are things that having long-term EEG data can be very, very revealing about.
And is the device suitable for people with focal and generalized, or both?
It is currently in the US approved for focal epilepsy. However, there was recently a trial that was completed called the Nautilus trial. It's not yet published, but it will soon be published. And that was a study that was done in people who had primary generalized epilepsy. And this was actually using that thalamic stimulation paradigm that I described earlier. And it turns out that the results of that were quite favorable, and the FDA is now mulling over whether to grant an indication for idiopathic generalized epilepsy as well. So that has not happened yet, but many of us are hopeful that may come to pass, because certainly that's a slice of the population that would be very much in need of new treatments.
Well, totally. And I presume, given your answer just then, it's not suitable or approved yet for things like, developmental epileptic encephalopathies or anything like that yet. That's right.
There are a smattering of case reports about the use of RNS off-label, mind you, for things like DEEs. There is an ongoing clinical trial that we are participating in, as well as 5 other centers in the U.S., looking at the use of RNS for treating Lennox-Gastaut syndrome, which is a symptomatic generalized epilepsy. And there have been many other, investigational uses of RNS for other things, including things that extend beyond epilepsy, believe it or not, like treatment-resistant depression and OCD and a lot of other things. So in a way, people are now starting to think that RNS really is a platform technology. This is a device, an intracranial device, that can detect activity that's of interest to you and respond with stimulation that might help to treat pathological brain activity in disease-relevant circuits. So that's a very exciting kind of high-level way to think about this device. Maybe not how it was probably conceived originally, but we're growing into that.
I was actually just about to ask you about any potential positive or negative effects on a person's, mental health, because that's, those symptoms commonly, unfortunately, come along with seizures. So it seems like you're saying that potentially it can be positive for people, for instance, with depression or OCD, or can it go the other way too?
I'm sure there's examples where it can go the other way. There are really promising early reports in a small number of patients showing that if you identify the right biomarker, for example, of mood state, you can use RNS to leverage that biomarker and treat people who don't have epilepsy but have treatment-resistant depression at, sometimes with really dramatically positive outcomes. It's early days, though. We have a lot to learn about what biomarker we should be looking for and how we should be calibrating the RNS device accordingly, how we should stimulate, where we should stimulate, what the time course of improvement is. But I think it's really promising for a lot of other indications, even beyond epilepsy.
Gives us some great realistic hope, I think. And I would encourage anybody who's interested in this to what would you say for anybody who's listening, whether they be a clinician or a person with an epilepsy and they want to learn more? Where should they go? Yes.
One place where patients who are considering this therapy go as a first stop for a good resource is the manufacturer is NeuroPace. That they have a website, which is www.neuropace.com. And there's a section for clinicians. There's a section for patients. And it's a good place where a lot of the relevant scientific papers are published, some instructional videos and patient testimonials, and if you even the evidence for what we know about the mechanism, the clinical efficacy, a lot of that is housed there. There are a number of online community groups that are dedicated towards RNS, and where the community of people who are treated with RNS therapy have come together to share stories and support each other and help us all learn collectively. There's only around 9,000 people in the whole world who have RNS currently. That number is growing, but certainly the best way to learn is to pool our collective experience.
No, indeed. And I think, for anybody interested in the papers that you've mentioned or upcoming papers, certainly give those a read as well.
Absolutely. Yeah. There's no substitute for, look at what's published, and all of the studies have limitations, obviously, and strengths. But the best we can do is look at the data that is available, the evidence that we have, and then think about how we might want to design studies to learn even more over time. I think RNS is at this really exciting place where it's largely been de-risked. We didn't talk too much about this, but the safety data that we've accumulated now since the first implant in the early 2000s is really quite favorable. There are, of course, risks to any brain surgery and any implanted devices, but we think of RNS as a very safe therapy. And now knowing that it is not only safe but effective now really allows us to sort of liberalize our thinking and say, well, how else can we use this? For what else can we use this? And what does a next generation device look like? Right. That's something that's super exciting too. We certainly are in an age where technology developments are very rapid and hardware and software are making just, giant leaps all the time. Medical devices are slower because they have to go through understandably a long regulatory process. But there's no reason why all the hardware and engineering advances couldn't be brought to bear on an even better device in the future.
Well, I have to say, you do make it sound like the latest iPhone or Samsung or something like that, but in a good way.
In a good way, yeah. Well, and just the same way that you might wish that your current iPhone has some more bells and whistles, and maybe next year you will get an iPhone that has some of those things. Those of us who use neurostimulation devices have our own wish lists, and we don't get a new one every year, but we can at least look forward to the next generation and hope that, the technology advancements continue, and hopefully that is accompanied by greater and greater clinical efficacy.
It's exciting, right? To know that something which can already monitor and stimulate the brain to reduce seizures is still being developed and refined, and to not only better control seizures, of course, but potentially to help with other conditions in the future too, including things like depression and OCD. A huge thank you to Vikram for sharing his knowledge and passion for how RNS may improve the lives of so many people with refractory focal epilepsy. Do subscribe if you haven't already, and see you next time.